Record. Okay, so this week, what we are beginning is our adrenergic and our cholinergic drugs. So chapters 18 and 19 are we're going to be going over our adrenergic drugs. So with it, what I say is when you start getting into these, try to make sure that you are focusing on what the receptors do, and it'll help you as we continue on. Okay, let me see here. I'm trying to pull out my notes real quick. Okay. So like I said, this first chapter, chapter 18, are our adrenergic drugs. So these are the drugs that have to do with the sympathetic nervous system. So before we begin, like I usually do, I like to kind of go over some of the anatomy and physiology stuff. So on this one, what we've got here is our nervous system is divided into two major branches. You've got your central nervous system, which is your brain and spinal cord. So you can kind of see it on this diagram here. We've got our brain and our spinal cord. And central, what I always think of with central is that's basically like the main thing that's happening. So it's the one that gives us thought processes and leads everything else to start going. Then we've got our peripheral nervous system, which is basically divided into subdivisions. You've got the somatic, which is the somatic system is basically our musculoskeletal system. So that's just like my arm can move back and forth. I'm consciously telling my body what to do. Then you've got the autonomic, which kind of happens by itself. It automatically takes place. And with that subdivision, we've got two different subdivisions. You've got the parasympathetic, which is our cholinergic, and our sympathetic, which is our adrenergic. And when you continue on, just make sure that you're paying attention to these things. And after we finish chapter 18 and 19, I'll show you this little diagram that I'll probably print off and give to you all. So this video here is very helpful. I went ahead and put it under your topic resources. So if you're looking for it, you can find it there. So once again, just kind of going down into the sympathetic nervous system and how this all breaks down. So like I said before, the peripheral nervous system has several different divisions. The first two divisions are the, sorry, I distracted you real quick. We'll put you on the sides, that way we can see everybody here. Okay. So you've got your parasympathetic system, which is going to be our chapters 20 and 21, our sympathetic system, which is our adrenergic system, and this is our checks and balances system for maintaining normal homeostasis of autonomic functions. And does everybody know what I mean when I say homeostasis?
Yes. Keeps a balance.
Exactly. It's how we basically keep everything balanced. And that's exactly what we're going to be talking about with this chapter 18 is all our checks and balances. When we get into the alpha and the beta, what we're talking about is vascular versus heart rate, but all of it's to basically maintain our normal functions. These adrenergic receptors are our norepinephrine and our epinephrine. So we've got our alpha adrenergic receptors, which is alpha 1 and alpha 2, and our beta adrenergic receptors, which is beta 1 and beta 2. We'll also briefly talk about our dopaminergic receptors, but the main focus are these alpha and beta receptors. So we'll go ahead and start with first our alpha receptors. So alpha adrenergic receptors, you've got two of them. You've got alpha 1 receptors, which causes that activation of receptors in the arterioles of the skin, visceral and mucous membranes, and veins, all leading to vasoconstriction. So what we're talking about here is in the vessels. Now, what happens to a lot of people is whenever they see hypertension or vascular, they kind of only assume with it just in like our blood pressure that we take in the arm, but you can actually have this vasoconstriction at other places. As long as it's got a vasculature in those vessels, that's what we're talking about. And with vasoconstriction, is my blood pressure going to go up or down?
Up. It'll go up.
Exactly. It's going to go up because if we think about it, have you guys ever had a hose and you like squeeze the hose and the pressure is much stronger than if you let it all go open? So that's what we're talking about here. So what these receptors do naturally is they cause that vasoconstriction. And it can be the vessels that are in our arms, or it can be the vessels that are where our eyes are located. It's all this smooth muscle contraction is what we're talking about. The alpha-2 receptors, they control the release of neurotransmitters. So what you have here is alpha-1 are located on the postsynaptic effector cells. So that's the tissue, muscle, organ, or the nerve stimulant. So what we're talking about here is this little postsynaptic neuron here, opposed to alpha-2, which are located on the presynaptic neuron. And what I always think of is, like a phone charger, that's kind of how I see neurons, is basically that electric current going through. So what you'll have is these alpha-1 receptors that are going to release the neurons, and then the postsynaptic alpha-2 release the neurons, and then alpha-1 are the ones where you're going to actually have that vasoconstriction. Does that make sense to everybody on what these alpha receptors do?
Yes.
Yes, so it's we're talking mostly about our vasculature on this one. The next one is we've got our beta adrenergic receptors. So you've got beta-1 receptors and beta-2 receptors. Beta-1 is all about the heart. So the way I always remember my beta-1 receptors is I only have one heart. So what happens with this is it causes heart stimulation, which causes increased heart rate, which causes increased myocardial contractility, increased rate of conduction through the AV node, causing improved cardiac performance. So all of this kind of leads into cardiac things. So if we're looking at this neuron here, what happens is the release of the nerves allows me to actually have that heart stimulation. So all of this happens very naturally. That's why it's the autonomic nervous system, because I can't really control my heart rate. It just takes place. The other thing that it does is the kidney activation. So it also can release renin. Your beta-2 receptors, the way I remember those is you have two lungs. So activation in the arterioles of the heart, lung, and skeletal muscles are going to cause vasodilation. So that's what's a little bit different about these beta-2 receptors, is they can cause this bronchodilation because they have that bronchial stimulation. Activation of the receptors in the iridian smooth muscle causes relaxation, delaying premature labor. And the activation of the liver and skeletal muscles causes glucogenolysis, which raises blood glucose. And all these little reactions here, when we actually look at the medications, you just want to remember what each of these receptors do. Because if you remember what each of these receptors do, then you will remember what the medication does, whether it's an agonist or an antagonist. So before we continue on to our other dopaminergic receptors, do we have any questions about our beta or our alpha receptors?
I don't.
Okay. So just kind of keep in the back of your mind, if I'm talking about alpha, I'm usually talking about blood pressure, vasoconstriction. When I'm talking about beta-1, I'm talking about that heart rate. Beta-2, I'm talking more about lungs, blood glucose, things of that nature. Our dopaminergic receptors, these are an additional adrenergic receptor. They're stimulated by dopamine. They cause dilation of the following blood vessels, which will result in increased blood flow. So they're things like our coronary, cerebral, renal, all these kind of areas that are going to have that increased blood flow. And if you think about it, if it's activated in the kidneys, it's going to cause renal blood vessels to dilate, which causes increased renal perfusion, reduces the risk of renal failure. So I like how your book kind of set this up. It's all in a chart, but we've got it separated here. This is just the responses to the stimulation. So for example, with our blood vessels, alpha-1 and beta-2, is going to cause vasoconstriction or vasodilation. Cardiac muscle, beta 1, increased contractility, AV node, increased heart rate, SA node, increased heart rate. And remember that your SA node is your natural pacemaker. So when these receptors fire off, it's causing that increased heart rate. Same thing with some of these muscle skeletal and sphincters. So I won't go through each of these individually, but it's just trying to get into the mindset of, if this receptor is going off, this is what I'm seeing. And then this is just that same thing we talked about, just kind of condensed into one chart. Okay, so let's go ahead and check our understanding. Which of the following adrenergic receptors will cause bronchodilation?
B.
Exactly. It is B. And the reason it is B is because that's the one that has to do with our lungs. Because remember, we've got 2 lungs, so it's the beta 2 receptors. And when you're studying this too, and you're looking at beta blockers versus agonist, sorry, antagonist, agonist, just if you remember these receptors, it makes a little bit more sense. So catecholamines are basically neurotransmitters that are produced by the SNS, and they're stored in the vesicles located at the ends of nerves. So they basically are just substances that can produce that symptomimic response. They're metabolized by 2 different enzymes. And what they kind of cause is that fight or flight. So I mostly just kind of have this slide here so that way you know what they're talking about when they talk about these catecholamines. So, oh, let me see here. Got a little message. Flip back over these slides. Yes, the slides should all be online now. I put them all on there right now, so they should be available for you to get. They should all be available now, Delana. So and I'm going to be recording this, like we're currently recording it right now, so that way you can go back and see these. So with our mechanisms of action, we've got basically 3 different types of mechanism of action. The first one is direct symptomimic, which means it binds directly to the receptor to cause a physiological response. So that means like at the neurotransmitter, it's actually causing that response. Indirect is the release of these catecholamines that we just talked about, which is going to be at the nerve endings, and it binds the receptor, causing that physiological response. And the final one is that mixed acting, where basically it's a little bit of reaction to the receptor, a little bit of releasing these neurotransmitters in order to get a response. And that's how pretty much most of these adrenergic drugs work. So the drug effects. When I say agonist, does that mean that I'm stimulating or blocking?
Stimulating.
Yes, exactly. So keep that in your mind. If it says agonist, that means that I'm stimulating these responses. So I'm seeing the receptors do what they do, just to a bigger extent. If it's blocking, that means, or it's an antagonist, that means I'm stopping it from happening. So looking at this, if we stimulate our alpha adrenergic receptors on the smooth muscle, that's when we're going to have vasoconstriction, relaxation of the GI smooth muscles, constriction of the bladder sphincter, contraction of the uterus, male ejaculation, contraction of the pupillary muscles of the eyes, so those dilated pupils. Because if you think about it, this is all causing that stimulation of those things. Stimulation of the beta 1 receptors. Remember, beta 1 is our heart. That's going to cause that increased force of contraction, increased heart rate, and increased conduction through the AV node. So when we talk about inotropic, what we're talking about is the modifying force of speed of contraction of muscles. So whenever you see inotropic, that's what that means. Chronotropic means change in heart rate. So that's why on here it's got a positive chronotropic effect. And then dromotropic just means conductivity of the nerve fiber. So that's why you're going to have more of that conduction through the AV node. So then we've got the stimulation of our beta-2 antinergic receptors, which on the airways, it's always going to result in that bronchodilation. Some other ones can be things like that glucogenolysis in the liver, increased renin secretion in the kidneys, relaxation of the GI smooth muscles. And all of these kind of side effects, stimulation, when we think about it, it's going to kind of connect later when we talk about what we'll see as a result of medications we give. So some of the reasons or indications or reasons why we'd use antinergic agonists, so these are the ones that are stimulating it, are for things like our respiratory indications. So for example, why would I want to use a bronchodilator? When would be a good time for me to use a bronchodilator?
When you're having an asthma attack.
Exactly, when I'm having an asthma attack, or even just trying to control my asthma because I want them to be open. Things like our overactive bladder, our cardiovascular vasoactive adrenergics, our vision issues, treatment of our nasal congestion. So these are all reasons why we would use these medications. So these are some of our respiratory indications, our symptomimics. We've got albuterol, ephedrine, epinephrine, all these kind of other ones that are bronchodilators, and they're all going to stimulate our beta-2 antinergic receptors. Now, epinephrine is interesting in the fact that we use epinephrine a lot. So we will use it for anaphylaxis, for our ACLS cardiac, as well as for acute asthma attacks. So that's why it's one of those drugs that I'm like, you definitely want to know it because it's one of those ones that you'll see quite often. And with these inhalers, whenever you're studying inhalers, whether it's for this class, NCLEX, or when you go out into the real world of nursing, well, you guys are already LPNs, so go out into, I guess, the registered world of nursing or even your current nursing now. Make a note as to which inhalers are your acute asthma attacks and which ones are your long-acting ones, because you want people to know what are their rescue inhalers versus what are their not rescue inhalers. Okay, so indication, treatment of a wide variety of illnesses and conditions. Remember, our respiratory indications, they're those bronchodilators. So they're drugs that stimulate our beta-2 antinergic receptors of the bronchial smooth muscles, causing that relaxation in the bronchus. So some of our examples, like we said before, things like our albuterol, our salmeterol, all these kind of inhalers that we use. So if you look at it, if we give this bronchodilator, it's going to open up our vessel here. Now with this, if I were to give a patient 2 different inhalers, and one's a bronchodilator and one is a steroid, which medication would I give first?
The steroid?
I would give the bronchodilator. And here's why, is because if I have that dilator, what did I just do to all my bronchus?
You opened them up.
Which is going to make it easier for the steroid to actually get inside through the bronchus, get into the actual alveoli. So that's the justification for why we dilate first and then send a steroid in. So that way we just get more, I guess, bang for our buck, if that makes sense.
Yeah, that makes
So we're going to start with our epinephrine. With a lot of these medications, it depends on the amount that you give. So you'll see this a lot with our cholinergic drugs when we get into chapters 20 and 21, and with these adrenergic drugs, is if I give more of the drug, I might have a more alpha response, or I might have more of a beta response. Each of the drugs is different when it comes to that. So with this epinephrine, if it's given, it can be both alpha 1 and beta receptors. So alpha 1, it's going to cause that vasoconstriction, which if I give epinephrine, what's going to happen to my blood pressure?
It's going to go up.
It's going to go up because I've got that vasoconstriction. With it, it's also going to cause increased heart rate, all that increased conduction. So my heart rate's also going to go up, and it's going to cause bronchodilation. So seeing how it can affect all these receptors, it kind of makes sense why that's our go-to drug for anaphylaxis, right? Because anaphylaxis, what happens to all my bronchus during anaphylaxis?
Tightens.
Those.
It tightens, exactly. It tightens, and since I can't get air in, my heart rate starts to drop, my blood pressure drops, everything's kind of going down. So in order to kind of fix that problem, I can give them epinephrine, which is going to cause my heart rate to beat. It's going to cause that vasoconstriction, so that way I'm getting a higher blood pressure and the bronchodilation. So that's why with this particular drug, it can do so many different things. So with it, these are some of our therapeutic actions. We've got our alpha-1 anaphylactic shock, slows absorption of local anesthetics. So what will happen a lot is in surgery, what they'll say is we're going to do lidocaine with like a dose of epi, because we don't want to give them too much lidocaine. So we're going to give them it with epinephrine in order to kind of slow some of that anesthetic. You can also manage superficial bleeding with it, decrease congestion of nasal mucosa, increase blood pressure. Our beta-1 receptors are treatment of our AV block, heart failure, shock, and cardiac arrest. So this is our ACLS kind of go-to with epinephrine. Now with this, our beta-2 receptor is for acute asthma attack. Now, if it's acute asthma attack, is this an inhaler I'm going to give every single day?
No.
No.
No. So on this one, if I was studying for it, what I would personally do is write rescue inhaler next to it. Because anytime that I see that it's for acute asthma attack on either my med book or in my pharmacology book, I'm going to note that this is a rescue inhaler. So with it, our nursing considerations, they all kind of make sense with what we just talked about. We want to focus on our vital signs, correct? Because if I give too much epinephrine, what can I potentially put my patient in?
Respiratory failure.
Potentially, I could put them in respiratory failure, or hypertension is the main one. Because remember, it's causing my heart rate to beat super fast, so I'm causing it to become very tachy. And then also, it's causing my blood pressure to go up. So that's why I want to make sure I'm still looking at my vital signs whenever I give epinephrine, as well as my breath sounds.
Didn't you give, cause someone to have like a heart attack if
Potentially you could. That's why these medications are very serious, and that's why we have to be careful whenever we give epinephrine. And that's why we usually reserve it only for serious situations, like our acute asthma attack, where if we're following the ABCs of nursing, that's my airway, I want to hurry, or that's my breathing, and I want to hurry and open things up so my patient actually breathes. So epinephrine is more your emergency drug.
Mhm.
You want to assess and document your liver and renal function tests, as well as your cardiac monitoring. Okay, so a patient has been prescribed the inhalation form of epinephrine. The patient asks what this inhaler is used for. What is the nurse's best response?
B.
Yes, it is used for acute asthma attacks. Like I said, you don't want to use the rescue inhalers as a maintenance dose, because that can end up causing them. It's basically like I'm giving an emergency drug every single day, opposed to I'm saving it for when I really need it. To control your blood pressure, that would not be the best way to control your blood pressure. And yes, you can check your blood pressure prior to taking it, but that's not really the best response. So you want to use that for acute asthma attacks. Our beta-2 adrenergic agonist, once again, if it's an agonist, we're stimulating. The prototype first medication, whenever you see that like prototype, that's the first one made, is our albuterol. And this is given for bronchospasms. If it's given for bronchospasms, do we think that it's for rescue or every day?
every day?
Rescue.
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 Yes, because bronchospasms, are something that can happen just out of nowhere. So usually your albuterol is given for rescue. And most of these will end in your Terol. Like we've got Salmeterol, Levobuterol, all these different type of Terols. So our Salmeterol is inhaled and long acting. So if it's long acting, that is one of my everyday inhalers. It's usually 1 puff twice daily, 12 hours apart. Long-term control of asthma. So this would be one of those ones that I would tell my patient, you can take this one every day. Now with this, it can only prevent asthma attacks, but not acute asthma attacks. So it acts by selectively activating the beta-2 receptors in the bronchial smooth muscle, which results in that bronchodilation. So the goal of this one is to basically kind of every day keep the bronchus just a little bit open. And most of them are combination, like you've got your Salmeterol and fluticasone. So whenever you see that SONE, that means that it's a steroid. So this inhaler here is basically going to cause the bronchus to open and then give that steroid dose simultaneously. So it's not to be used for the relief of acute symptoms, and education is very important because if you think about it, a lot of school-age kids have asthma, and you just want to make sure that they know, okay, if you're by yourself, this is the one that you take, this is the one for every day. So Salmeterol is only used for prevention, not acute attacks. It's not used alone. It's usually given with a glucocorticoid. So whenever you see corticoid, what we're talking about here is our steroids. For administration, you want to give that bronchodilator first, then give the inhaled glucocorticoid. Just some of your nursing implications with chronic lung disease. You want to instruct the patient to avoid factors that exacerbate their condition. So for example, if you're allergic to cats, sorry, but you're not going to be able to be around mittens. And a lot of people don't quite understand this portion of it, is that avoiding those things that are going to exacerbate it. You want to encourage fluid intake if permitted, and then educate about proper dosing, use of equipment, and equipment care, and then appropriate use of inhalers. So I'm very big on the rescue versus maintenance. So like I said, whenever we go over inhalers, just make sure that you're writing, this is my rescue, this is my maintenance. So you want to monitor for your therapeutic effects. So return to normal respiratory rate, improved breath sounds, fewer crackles, increased air exchange, decreased cough, less dyspnea, improved gas exchange, increased activity tolerance. So a patient has 2 inhalers that are due to be taken at the same time. One is a bronchodilator, the other is a corticoid steroid. Which inhaler should the patient take first?
A.
Hey,
Yes, the bronchodilator. We know that one now. So the other thing that we can use these adrenergic agonists for is treatment of nasal congestion. So intranasal application causes constriction of dilated arterioles and reduction of nasal blood flows, thus decreasing congestion. So that's your alpha-1 adrenergic receptors. Because remember, it's all about, the alpha is all about the blood vessels. So if you think about it, if I cause that vasoconstriction in the arterioles of that nasal passage, then I'm going to decrease the congestion because I'm not releasing as much of that congestion up in that area. Now, this is just like a general kind of rule of thumb with your decongestants. Overuse of nasal congestants may cause rebound nasal congestion or ulceration. So this is why your doctor will usually prescribe you a nasal decongestant for about 2 to 4 days, and then they tell you to like stop or come back to the provider, just because it has that rebound where it will be worse than it was before. You also want to avoid over-the-counter medications, just because that possible interactions. So some of our ophthalmic indications can be that temporary relief of that congestion in your eyes. So these are our alpha adrenergic receptors. Once again, we're seeing that epinephrine again. It can also be used for the reduction of intraocular pressure and dilation of pupils. So it can be used for the treatment of open angle glaucoma. Because once again, it's causing that constriction, so it's going to cause dilation of the pupils. So our overactive bladder indications, relaxation of the dorsal muscle during the storage phase of the bladder fill cycle, and that can increase our storage capacity. And one of the drugs is that myrovigeron. Okay, so now we are going, does anybody have any questions about those ones before we jump into our pressors?
No, I don't.
Okay.
What was that last, Mayo, that last slide, Mayo, what?
Oh, Myra by Grayon. It's one of the medications we use for overactive bladder. So it's, if you have overactive bladder, you can take that medication, and it just helps by basically relaxing that muscle. So that way they can hold more storage in that bladder fill cycle.
I just noticed that, okay, so on that one inhaler,
Mhm.
it was fluconazole, which is the same thing as Flonase. See that one right there?
Let me see here.
It's the green one.
Yes, so yes, they can have, so Flonase is a type of steroid that you can use as well. So some of your inhalers will actually have that connected with too.
So they're the same thing. Okay.
Yeah. So a lot of these medications will be the same thing. It's just how the dosing is can change the reaction that it has. Okay, so we're getting into, these are kind of like your, I call them like your ICU intensive care medications, because these are our pressors, our iniotropes. So they're also called our cardioselective symptomimics, and they're used to support the heart during cardiac failure or shock, and they have both various alpha and beta receptors affected. Because if you think about this, these are when things are kind of going south and we want to kind of jumpstart the heart, or we want to pull up the blood pressure. So there's quite a few of them. We've got things like our dopamine, our midodrine, our dopamine, our epinephrine, our norepinephrine. So with our counterindications for pressors, known drug allergies, because obviously if they're allergic to it, I don't want to give it to them, and severe hypertension. Because if we remember, all of these things are going to cause our blood pressure to go up. So I don't want to give them something that's going to cause it to go, if it's already up, I don't want to make it higher. So some of our adrenergic alpha side effects would be things like headache, restlessness, excitement, insomnia, euphoria. And if you think about this, if my blood pressure is going up, it kind of makes sense why I would be very restless, why I would have this chest pain, this vasoconstriction, this palpation, these dysrhythmias. All of these things kind of make sense because I'm basically putting my body in that fight or flight mode where I'm just getting ready to like either run away from something or I'm getting ready to fight something. Now, what can also happen is this reflective bradycardia where it goes up really, really high, but then it kind of slows down. And that's just because it's like your heart is going and going and going and going and going, and then it just needs to rest. Our beta adrenergic drugs can have mild tremors, headache, nervousness, dizziness, increased heart rate, palpation, fluctuation of blood pressure, sweating, nausea, vomiting, muscle cramps. And if you think about it, sorry, if you think about it, it kind of makes sense. Because if you ever had your heart race really, really fast and it just feels like everything's just kind of getting at you, you feel like you're gonna like faint. It's like right before a test, you feel all these things.
Oh, yes.
Oh, yes. Oops. So our toxicity and management of overdose. So especially when we get into chapters 20 and 21, make sure that you know if a medication has an antidote, you know what that antidote is. And same thing with this, our toxicity and management of overdose. Because I want to know, because a lot of these drugs, especially these beta and alpha and anergic drugs, a lot of these, the nurse is the one titrating the drug. So we're the one who's putting more of that medication through the IV pump for the patient. So I want to be able to know, okay, is something going on with my patient? What's happening with them? So what do I need to do? So with it, from excessive CNS stimulation, you can have things like seizures, intracranial bleeding due to the extreme elevation of blood pressure. So with that one, effective treatment would be that rapid acting sympholytic drug. And one good thing is a lot of these drugs do have short half-lives, so the effects are short-lived. And you want system management and support the respiratory and cardiac systems. So you just want to make sure that you're watching your patient in a holistic way. And a good rule of thumb is assess your patient, not the machine. Because when I was working in the ICU, what I would see a lot of people do is do it based off of the machine and not the patient. You always want to go to the patient first and then look at the machine. So that way you know, okay, is my machine saying something or is my patient actually feeling these things? Because machines are only as smart as the person who sets them up, right? So kind of keep that in mind. So they can have different interactions, things like our MAOIs, so our antidepressants, our antihistamines, our thyroid preparations, our anesthetic drugs, our adrenergic antagonists, and other kind of numerous drugs like that. All right, so the first drug we're going to talk about is our dobutamine. So it's a beta-1 selective vasoactive adrenergic drug. So that means, is this one affecting mostly my heart or heart and lungs?
Your heart.
My heart, yes. So this is one of those drugs that they would give if I want to basically deal with the heart. So we're looking more at a heart medication. It's very similar to the catecholamine dopamine. So dobutamine is a little bit different than dopamine. So when we give dopamine, we're giving basically a synthetic version of the dopamine we make naturally. Dobutamine is very similar to it though. It stimulates beta-1 receptors on the heart muscle, which causes that increased cardiac output by causing that increased contractility, which increases stroke volume, especially in patients with heart failure. So whenever we talk about cardiac output or contractility, what we're really talking about is the drive of force of the heartbeat. So the better the heartbeat I have, the better blood flow I'm getting. So it's an intravenous drug given by continuous infusion. So usually these drugs are given Viva through central line because most of these drugs are very toxic to the tissue. And you'll see it later because I've got some pictures later on when we continue. If they get into the tissue, they can cause extravasation, which is basically that destruction of tissue. So if you see that your patient's on these, you just want to make sure that you're being proactive and that we're getting either a PICC line or a central line for them to go into. And what I say is if a drug can kill you within 10 minutes.
But what about a midline?
Oh, what did you say? I'm sorry.
What about a midline? Can it go through a midline?
Usually not, because a midline, it's a little bit longer and you might be able, well, I would personally prefer a PICC line because it's going to go all the way through to the heart itself. A midline, you can technically give it through a midline. It's just preferred to have an actual central line with it. But yes, it can go through a midline. Some of these can actually go through peripherally. It's just better for the patient if you can get that central line. And most physicians know about these ones. Just because a midline is just slightly longer than a peripheral line. So there's still that kind of, it's not as much of a risk because it's going deeper in, but I would just feel safer to have a peripheral line or a central line.
Okay.
Now, if there's like absolutely no way and all you've got is a midline, you can push these drugs through a midline. Okay. So our dopamine. So these are the natural occurring catecholaminergic neurotransmitter. It has that potent dopaminergic as well as beta 1 and alpha 1 adrenergic receptor activity. So if it's got both beta 1 and alpha 1, we're looking at increased heart rate as well as vasoconstriction, so increased blood pressure. And this is what I was talking about with the different doses. So low doses can dilate blood vessels in the brain, heart, kidneys, century, which increases blood flow to those areas. So that's where we have that dopaminergic receptor activity. Higher infusion rates improve cardiac contractility and output. So that's the beta 1. And highest doses are usually your vasoconstriction, which is going to have that blood pressure improvement. So with this, what you'll usually see is if a patient's in shock, they may be placed on this dopamine drip, which is intended to have that effect of blood pressure improvement. Because a lot of these dopamine drips would be considered that higher dose because you're having that continuous infusion of the drug. Epinephrine, we're seeing that epinephrine again. With this, it acts directly on both alpha and beta adrenergic receptors. It can be administered in emergency situations, and it's one of the primary vasoactive drugs used in many advanced cardiac life support protocols. So that's where you'll see during like a code, they might say, we're doing a round of epi, or I need epi to go through. That's what we're talking about, is this epinephrine, because I'm trying to make sure that I'm pulling it up, because this one can affect alpha, beta 1, and beta 2. So midodrine is a little bit different than the other ones because this one is actually an oral dosing. So this is one of the few ones that a patient could potentially go home on. So this is usually given to our patients who have very low blood pressure, and they just always seem to have low blood pressure. So it's an alpha 1 adrenergic receptor stimulator, which constricts the arterioles and veins, resulting in peripheral vasoconstriction. And it should not be given within 4 hours of bedtime. So this one's usually a morning dose because we want their blood pressure to kind of be up during the morning time. Mirabegron is a beta 3 agonist. So we didn't talk much about the beta 3 agonists, but with this one, it's mostly for that overactive bladder. And that's what your beta 3 kind of area does. It has to deal with that bladder area. And what this one does is it causes that increased bladder capacity. Your adverse effects are things like hypertension, possible UTI, headache, nasopharyngitis, nausea, dizziness. Norepinephrine or Levophed. This is one of our alpha adrenergic receptors. And this one is one of the reasons why I'm so passionate about safe dosage range, because in the ICU, we would mix norepinephrine a lot during emergency situations, because sometimes you can't get it from pharmacy fast enough. And with it, there's a huge difference between a 250 ml bag and a 400 ml bag. So that's where it becomes important that we know that we're giving the right amount of medication within the bag. Because if I was supposed to have a 250 bag and I gave a 400 ml bag, what did I just do to my patient? Did I give them too much or too little?
Too little?
Too little, exactly. And if I'm trying to bring up their blood pressure and everything, then I might be titrating my drug inappropriately because I mixed it wrong. So that was something that I always pushed a lot when I was training people, is to make sure that you're looking at your concentration. Make sure that you're putting in the right concentration, because I could end up doing that. And then if somebody gets the appropriate mixed drug, but leaves it at the same titrating that I just put the patient in, then I could end up having it where the patient's not getting the right amount of medicine. And I wish I had the bag to show you guys, because it would make a little bit more sense actually seeing what I'm talking about. Uh, but basically, it's so that way we're all consistent about how much they're getting. So with this, they stimulate the alpha, but no stimulation of the beta-2 adrenergic receptors of the lung. So this one would be safe for a patient that has asthma. It causes vasoconstriction, usually a treatment of hypotension and shock. Once again, this is administered by continuous infusion. So in emergency situations, we can give this one through a peripheral line, but honestly, you want to get that central line as soon as possible. Buprenorphine works almost exclusively on the alpha adrenergic receptors, and it's used primarily for short-term treatment to raise blood pressure in patients in shock. It can control our supraventricular tachycardias, vasoconstriction in regional anesthetics, topical ophthalmic drug, and nasal decongestants. So you'll see this in different varieties. This is why I talked about, depending on the dosage, you'll see different reactions of the medication itself. Well, I have a video too that I posted online that you can watch that kind of goes over that one a little bit more. So administering two adrenergic drugs together may precipitate severe cardiovascular effects such as tachycardia or hypertension. So you want to be careful with this. When I was in the ICU, we would have quite a few different drugs that the patient would be on. And my goal was always to try to put them on the least amount of medications that I could. So I would go through their history and see what kind of history they had, so that way I could titrate one drug down and maybe see if another drug might work better. And the reason for that is because, like I said, these drugs, if you put on too many of them, then you might be ending up pushing them to too much heart rate or too much blood pressure. You want to watch for therapeutic effects, things like decreased edema, increased urinary output, return to normal vital signs, improved skin and temperature, and increased level of consciousness. So one of the things that was really neat in the ICU though to see is you could always tell your patient was getting better if they had increased urinary output, because that means that instead of trying to hold everything in to keep their pressure up, their body could actually release that urinary output. So that's something that I would always look for, is to see how's their urine doing. So our intravenous IV administration, check the IV site often for infiltration. So whether it's a central line, peripheral line, midline, whatever you have, always check your site. Because the thing is, patients can move around and they can pull things out. And the last thing you want is one of these medications to infiltrate into the tissue. Use clear IV solutions. So you want to make sure everything is clearly labeled. Back when I worked, I would label the pump, I would label each of my tubings, I would label the bag, I would put the dates, I would basically try to make sure everybody knew exactly what was going through. Use an infusion pump. Like I said, if it can kill you within 5 minutes, it deserves a pump. Infuse drugs slowly to avoid dangerous cardiovascular effects. So that's where titrating comes in. So that's one of the things that is kind of a difference between LPN scope and registered nurse scope, is because we as registered nurses get to titrate these drugs. And when I say titrate, what I mean is we get to say if the patient should get more or get less of the medication. And that all comes back to our assessments. And then monitor your cardiac rhythm. So make sure you're watching, is my patient's heart handling this? Okay, so a patient is experiencing bronchospasms after running a mile. He has several inhalers with him. Which one would be appropriate for treatment at this time?
A, the albuterol.
Yes, exactly. Salbuterol is for our bronchospasms. Salmeterol, is that one an acute, or is that a rescue or a maintenance steroid?
A maintenance.
Yes, that one's maintenance. And fluticasone, is that a bronchodilator, steroid, or what is that one?
A steroid.
And then that salmeterol and fluticasone combination, is that one is once again a maintenance dose. Okay, so a patient is on a dobutamine drip, starts to complain that her intravenous line hurts. The nurse checks the insertion site and sees that the area is swollen and red. What will the nurse do first?
B.
Yes, stop the infusion. As soon as your patient says, my line hurts, then I'm going to stop the infusion. And that's because I'm going to check it before I just keep on letting things go. A patient on a dobutamine drip starts to complain that he feels a tightness in his chest that he had not felt before. What will the nurse do first?
C.
Yes, check the patient's vital signs. And the reason for that is because is anywhere in this question indicating that this is an issue with my IB site?
No.
No. And since he's talking about tightness, what did we say dobutamine does to my heart rate? My blood
It-
pressure.
It
It increases it.
Exactly, it increases it. So the first thing I'm going to do is check the easiest thing I can check, which is my vital signs. And because it said first, that's the first thing. After I check vital signs, then I might look at an electrocardiogram. But right now, the first thing I want to do is get that set of vitals and make sure that I didn't accidentally titrate it too high, and now everything's going up too much. Okay, a 10-year-old child is brought to the emergency department while having an asthma attack. She is given a nebulizer treatment with albuterol. What is the nurse's immediate assessment priority?
B.
Yes, because once again, is there anything, does asthma typically cause a temperature to go up?
No.
No. Asthma can be caused by exasperation of things like I'm allergic to flowers, but it's not going to necessarily cause me to have an increased temperature. Can I wait on education?
Yes.
Yes.
Yes. If it's between educating and making sure somebody's breathing, I'm always going to go with breathing first. I don't really need to know the child's last meal at this moment. So my priority is making sure I'm looking at that pulse oximetry. Okay, if you guys want, we will take a 5-minute break and then we will come back and do chapter 19.
Okay.
We'll go ahead and jump back in. Okay, so chapter 19 is adrenergic blocking drugs. So the last one was all about agonists, so things that are going to stimulate. Now we're getting into antagonists. So adrenergic blockers bind to the adrenergic receptors, but inhibit or block stimulation of the sympathetic nervous system, and they have the opposite effect of adrenergic drugs. They inhibit or lyse sympathetic stimulation. They're also known as adrenergic antagonists in sympholytics. So they can be called things like alpha blockers, beta blockers, or alpha beta blockers. And they're basically classified by the type of adrenergic receptors they block. So you'll have things like your alpha 1, alpha 2 receptors, and beta 1 and beta 2 receptor blockers. So your mechanism of action for your alpha blockers, remember before we get into this, what did your alpha receptor do? Did it cause vasoconstriction or vasodilation?
Vasoconstriction.
Vasoconstriction, exactly. So if I'm blocking that, what do you think is going to happen to my blood pressure?
It's going to decrease.
Dilation.
It's going to have that vasodilation. So when I'm talking about alpha blockers, they can cause your blood pressure to go down. So when I would use these drugs is to use it to treat things like hypertension, because they cause both arterial and venous dilation, which reduces that peripheral vascular resistance and blood pressure. Effects on the receptors on the prostate gland and bladder decreases resistance to urinary outflow, thus reducing urinary obstruction and relieving effects of benign prostatic hyperplasia. So it's used a lot in our prostate medications. So with our alpha indications, we've got our alpha blockers. They're used to control and prevent hypertension in patients with phenochromocystoma, which is a tumor in the adrenal gland. So up here you'll see, I always think of the adrenal glands as like the hats of the kidneys because they rest right up on top of them. And what happens is you'll have too much adrenaline released from the adrenal glands, and that's what causes that tumor. So what you'll use is this medication that can kind of help with that. Raynaud's disease, frostbite, acrocynosis, phentolimon quickly reverses the potent vasoconstriction effects of exacerbated vasopressors, such as norepinephrine and epinephrine. So this is one of those ones I was talking about. This phentolimon is a reversal agent. So let's say that one of these vasopressors extravasated, sorry, they infiltrated and caused extravasation in the tissue. I can give this medication here to fix it. It restores blood flow and prevents tissue necrosis. When phentolimon is used to diagnose the presence of phenochromocystoma, the nurse will assess for what indicated finding.
A.
Yes, because remember, this is one of our alpha blockers. So if it's an alpha blocker, it's going to cause that decrease in blood pressure. So these are just some of our adverse effects. Once again, I'm not going to go through every single one of these. It's just kind of good to know what's going to cause. So if I give too much of a blocker, then I can cause hypotension, edema, chest pain, tachycardia, palpitations, anything of that nature. When administering an alpha blocker for the first time, it is important for the nurse to assess the patient for the development of what adverse effect?
B.
Yes, hypotension. Because if we think about it, alpha blockers are messing with our vasculature. So I'm concerned about that hypotension. Some of our counterindications would be things like known allergies, coronary artery disease, peptic ulcers, sepsis, hepatic and renal disease, and peripheral vascular disease. With peripheral vascular disease, if you think about it, a lot of the peripheral vascular disease, what its main concern is getting that blood flow. So if I'm giving them a medication that's going to decrease blood flow, then that's why it would be counterindicated, because all of these kind of have a reason why they're counterindicated. So these are some of our common alpha blockers. So our phentolimon, which I was talking about before, it's an alpha blocker which reduces peripheral vascular resistance and is used to treat hypertension. It can establish a diagnosis of that phenochromocystoma, because if we remember, we give that one and we see that rapid decrease of blood pressure, then that can help establish that diagnosis. Most commonly, it's used to treat extravasation of vasoconstricting drugs, such as our norepinephrine and our epinephrine and our dopamine. So this is the extravasation that I was talking about, is on this arm here. You can kind of see where it's completely blown up and it's completely destroyed that tissue. So with it, you can give them this medication. Hopefully we won't completely lose that arm. It's counterindicated in known hypersensitivity, myocardial infarction, and coronary artery disease. So artemisinin is an alpha blocker used primarily to treat benign prostatic hyperplasia. So that would be prostate, like enlarged prostate. Because whenever you see hyperplasia, what that basically means is increased tissue growth. It's exclusively indicated for male patients. However, it can be used in females with kidney stones. So the reason it's mostly used in males is because it has to do with the prostate. So if it's a prostate, then it's male. Counterindications would be things like known drug allergies, concurrent use of erectile dysfunction drugs, such as our sildenafil. Whenever you see a fill, those are usually your erectile dysfunction drugs. Adverse effects are things like headaches, abnormal ejaculation, rhinitis, and some other issues. So our beta blockers, and these are just general across the board about our beta blockers. They block stimulation of the beta receptors in the SNS, because what did my beta 1 receptors do?
They had to do with the heart.
Yes, so that was all increasing heart rate, contractility, everything of that nature. What did my beta 2 receptors do?
The lungs.
Yes, that was the one that caused bronchodilation, as well as it can cause that genolysis in the liver. So looking at this, these beta blockers will compete with norepinephrine and epinephrine. They can either be selective or non-selective. So when we say a beta blocker is selective, what we're talking about is cardioselective beta blockers or beta 1 blocking drugs. So these are ones that are only going to affect the heart. Non-selective beta blockers block both beta 1 and beta 2 receptors. And when you're studying your beta blockers, it's important to know which ones are beta 1 and which ones are beta 2. And the reason for that is because if it causes the opposite of bronchodilation in a beta 2 receptor, what is going to happen to my bronchus?
Constrict, aren't they?
Exactly, it's going to constrict. So that's why if it's a non-selective beta blocker, then I wouldn't want to give it to a patient who has asthma, because that's kind of like counterintuitive, correct? Instead of causing that
Yes.
vasodilation, I'm causing vasoconstriction. So that's why you'll see things like metoprolol given so much, because metoprolol is a cardioselective beta 1 blocker. So you tend to see that one given a lot more than something like for like known asthma patients, instead of something like propanolol, which is a beta 2 blocker. Beta 2 receptors are located primarily on the smooth muscles of the bronchioles and blood vessels. So you can have intrinsic symphyomimic activity. So this is what it's basically saying, is that not only blocks beta adrenergic receptors, but can also partially stimulate them. So with some of these, you just have to be careful, because it's going to both simultaneously block as well as slightly stimulate. Things like carvedilol and labetalol are alpha receptor blocking activity, especially at higher doses. So you have to be careful with it. That's why they say you can only give so much labetalol, because you might end up making it that alpha receptor as well. Just as that refresher, our beta 1 receptors are located primarily on the heart. Those are cardioselective. Our beta 2 are located on the smooth muscles of the bronchioles and blood vessels. So our beta 1 blockers are going to have the opposite effect of what our beta 1 receptors did. So it's going to reduce the SNS stimulation of the heart, decrease heart rate, prolong our SA recovery, slow conduction through the AV node, and decrease myocardial contractility, thus reducing myocardial oxygen demand. Our non-selective are going to be both beta 1 and beta 2. So they're going to cause the same effects to the heart as cardioselective, but they're also going to constrict the bronchioles, resulting in narrowing of the airways and shortness of breath, and produce vasoconstriction of the blood vessels. So these are some of our indications. It can be things like angina, so that's that chest pain, decreases the demand for myocardial oxygen. Cardioprotective, inhibits stimulation from circulating catecholamines, used in patients who have had an MI, dysrhythmias, class 2 antidysrhythmic, and migraine headaches. So antihypertensive, so the ability to reduce the SNS stimulation of the heart, reducing heart failure and force of myocardial contractility is all how we do this antihypertensive. Heart failure and glaucoma. So I just kind of wanted to briefly talk about heart failure. And the way I think of heart failure is I first start out with, what does the left side of the heart do? Does it pump blood out to the body, or does it bring blood back to the heart?
It brings blood back to the heart.
So the left side is the one that helps pump it through the body. So the left side of the heart is what's pumping the blood out into the body. The right side of the heart is the one that's going to pull the blood cells back into the heart. And if you think about this, because heart failure is basically just my heart's not pumping the way it should. So instead of my heart having that nice pump that it's supposed to have, my blood is either getting stuck in the lungs or it's getting stuck in the vessels here. Left-sided heart failure is usually what people will start with. And what's happened is you use your left ventricle a lot because that's the side of the heart that's mostly pumping out, and it basically kind of gets weakened and all of that blood kind of pools into that left ventricle. And what happens is it pushes back into the lungs because it can't come out into the rest of the body, so it pushes into the lungs. So that's why with heart failure, you'll see things like cough, crackles, wheezing, all these kind of lung associated. So I always think of left side lungs because all of it's kind of pulling into the lungs, because instead of pumping out into the body, I'm pushing back into the lungs. Right-sided failure, which usually happens after left-sided heart failure, unless you've got core pulmonal. What happens there is all of my fluid is stuck in my tissues. You see how this poor woman here has like ascites and all of the fluid stuck here? It's because it's not pulling back. So instead of getting that blood to come back through the heart, it's just kind of letting it stay where it's at. Now with both of these, one of the main things you want to look for is things like weight gain, edema, wheezes, crackles, anything that's going to indicate that they might have heart failure. Any questions about that brief kind of conversation about heart failure?
I don't have any.
I mostly want to talk about it because some of these drugs are used for heart failure. So I want you to know what the signs and symptoms are of heart failure. So that way, if somebody is on a medication and they start developing these symptoms, you can be like, oh, that looks like heart failure. And you can kind of let the doctor know, because they might want to put them on a fluid restriction, or they may want to add another medication to them. Okay, so
we said,
sorry.
the only question I had was, the left side of the heart pumps it to the body.
Yes, the left side of the heart pumps it out to the body. So if it's not pumping it out to the body and it's pushing back in, that's why it ends up in the lungs. The
So
right
it
side of the
pools in the
body.
lung.
I'm sorry?
It pools in the lung. That's
Yes,
why you
so-
have a buildup of fluid in the lung.
Yes, let me pull out a picture of the heart just so that way you can see what I'm talking about here.
I think that's what I was thinking of when I said what I said a while ago.
Yeah, because we were talking about it and I was just talking about like the normal version of it.
Yeah.
So if you look on here, we've got our left ventricle here. So what happens in heart failure is this left ventricle here will basically have hypertrophic. It'll become hypertrophic, which basically means that it becomes almost engorged. Like, let me show you hypertrophy. Okay, and when you see that it's engorged here, instead of pumping out through this area here to get to the body, it ends up just pulling back in and going into the lungs. So that's why with congestive heart failure, you'll see all those lung symptoms of your patient, because they're not actually getting it into the tissue, because this is just so engorged through here. Does that make a little bit more sense with heart failure?
Yeah, okay. Yeah, it
Yeah.
does. Thank you.
Sorry, and you said with heart failure, they usually get left-sided first and then get right-sided, correct?
Yeah, yes, and if it makes sense too, because what are we going to strain more, the pushing or the pulling?
The pushing.
Exactly. So especially with some of our older adults who are using quite a bit of heart muscle, I almost the joke I used to make with my patho students is it's like your little heart gets like really jacked. Like, you know, those people who work out all the time, it's almost like that, where they've just developed all of this muscle here, where now it's becoming more difficult for it to push through from there, because there's a lot less space here for the blood than there is on this normal heart. Okay. I'm gonna skip that question. I don't really like it. All right, any other questions about heart failure?
I don't have any.
Okay. So these are our counterindications for our beta blockers. Obviously, if they're allergic to the medication, I'm not going to give it. Things like severe pulmonary disease, Raynaud's disease, cardiogenic shock, uncompensated heart failure, heart block, bradycardia, and pregnancy. And then these are some of the adverse effects that we can see. Okay. So beta blocker, because remember, I always say that you want to know with your management of overdose, so you want to know your toxicity of these different drugs. So we do it based off of symptoms. So we do symptom support, so supporting care. So if my patient isn't having symptoms with a low heart rate, then I'm not as worried as somebody who's having the obvious symptoms. So with it, if I give a beta blocker and that causes decreased heart rate, one of the main things I'm going to be looking for is bradycardia. And if they have bradycardia, then I'm going to give them this medication called atropine. And atropine is one of those other drugs that you want to make sure that you know. We'll talk about it when we get to our chapters 20 and 21, but that's one of the ones that you want to know. Cardiac pacing, which here we've got this picture of an internal cardiac pacer, but you can also get a subcutaneous pacer in emergency situations where you'll put the pacer on the outside of the skin, and it kind of basically kind of gets the heart to start pumping again. Vasopressors for severe hypertension, and hemodialysis to enhance elimination in severe overdoses. So when things get really, really bad, then we can use hemodialysis. So these are our cardioselective beta blockers. So I separated your non-selective and your cardioselective. So all of these are our beta 1 blockers. So all of these affect just the heart. So the first one we've got is atenolol. It's a cardioselective beta blocker. It's commonly used to prevent future heart attacks in patients who have had one. It can also be given for hypertension and angina, management of thyrotoxis to help block the symptoms of excessive thyroid activity, and it's available in oral use. Now, one of the main things you want to tell the patient is never stop this medication abruptly. Now, when you're working on the floor, because all of you guys work as LPNs, there may have been a time where you held a medication or you asked the nurse if you should hold the medication. That's different than a patient stopping the medication. With atenolol, you do not want them to just stop it abruptly. If they're having issues with it, you want them to talk to their provider, and then they can have a gradual decrease of it, or the doctor can decide then if he wants to stop it. Asamolol is a very strong, short-acting beta blocker. It's usually administered through IV. It's used in acute situations to provide that rapid control of ventricular rate in patients with supraventricular tachydysarrhythmias, which you'll learn about those, I think, in Med-Surg 3. But basically what that is, it's a heart rate of above 170 that it's very, very fast. Metoprolol, it's the most commonly used beta 1 blocker. I think there's a lot of patients that are on this one. It can be given both oral and injectable, and you just want to monitor them closely when you give it through IV. So these are all our non-selective beta blockers. So these ones can hit both your beta 1 as well as beta 2. Carvedilol is non-selective beta blocker and alpha blocker, a calcium channel blocker, and possibly an antioxidant. Its uses are for heart failure, hypertension, and angina. It slows the progression of heart failure and to decrease the frequency of hospitalization. And it's most commonly added to digoxin, forsamine, an angiotensin converting enzyme inhibitor when used to treat heart failure. So carvedilol is mostly used for our heart failure patients. Propranolol, it's got multiple uses. And once again, this is one that's going to hit both beta 1 and beta 2 blocking receptors. So it can be used for subarachnoid stenosis. So this is that stenosis there, where it's that obstructing ridge below the aortic valve here. It can also be used for your tachydysarrhythmias and your migraine headaches. Cetalol is a potent antidysrhythmic. indicated for the management of difficult to treat dysrhythmias. With all of these beta 2, remember that it causes that bronchoconstriction. So we would be concerned with our asthma patients. Okay, so the nurse knows that the adverse effect of a non-selective beta blocker are likely to be most immediately life-threatening to which patient?
I'm gonna go with B.
Yes, not just because I said it right before then, but yes, it is B. Because with this, while it is concerning that a patient has diabetes type 1, I'm not nearly as concerned as my breathing. Because remember, always remember your ABCs of nursing. It goes airway, breathing, circulation. So the very first thing is I have to make sure I've got a patent airway. So I want to make sure that my trachea is open. And after that is my chest moving up and down. And then do I have enough blood going everywhere? So our beta blockers adverse effects. So non-selective beta blockers may interfere with normal responses to hypoglycemia. So it may make it so the patient does not show those tremors, tachycardia, or nervousness. So it's going to mask signs and symptoms of hypoglycemia. Because if you remember, those beta 2 ones affected the liver and their ability to have that glycolysis. So you want to be cautious with patients with diabetes. So whenever you monitor or whenever you're providing education, the thing you want to stress the most to these patients that are on these non-selective beta blockers is to monitor your blood glucose for high or low abnormalities. They can also result from either an additive effects of co-administrated medications. So if you give medications of the same antagonist effects, then you can have that additive effect. And once again, those non-selective beta blockers can mask that hypoglycemic. So with it, there are nursing implications. Assess for allergies, history of COPD, hypotension, cardiac dysrhythmias, bradycardia, heart failure, and other cardiovascular problems. Any pre-existing condition may be exacerbated by the use of these drugs, so it might be counterindicated for their use. So the thing you want to remember though on this is if my patient has COPD, would I want to give them a beta 1 or a beta 2?
Beta 2.
And if they have COPD, am I going to want to cause that bronchoconstriction?
Beta 1.
Beta 1, yeah.
Exactly, beta 1. So this is where when you're going over medications, because the thing is we don't prescribe as nurses, like for RNs do not prescribe unless you're a nurse practitioner, but we can catch things. So for example, if I have a patient who the doctor didn't know that they had asthma in their history and they're currently on carvedilol, and I find out they have asthma, then I can let the physician know, hey, they've got asthma and they're on carvedilol. So then the doctor might say, okay, I'm going to switch them to atenolol instead. And it's going to have the same effect for the patient. It's just going to be better. So that way I'm not causing a future problem. So that's why we kind of push so much of knowing what these side effects are. So remember that alpha blockers may participate hypotension. So you're watching for that hypotension. And that beta blockers may participate bradycardia, hypotension, heart block, heart failure, and bronchoconstriction. So with it, you want to watch and avoid for over-the-counter medications because of possible interactions, and also interactions that may occur with things like antacids, our anti-muscarinics, or our anti-cholinergics, diuretics, cardiovascular drugs, our neuromuscular blocking drugs. Because remember with when we're talking about the agonists, we would give epinephrine with some of our anesthesia agents to prolong it. So if you've got one that's blocking it, then it may cause an issue with our neuromuscular blocking drugs. Oral hypoglycemic drugs as well. On here, you want to encourage the patients to take medications as prescribed. So like we said before, you don't want them to just stop these medicines abruptly. You want them to gradually get off of them if they're going to, but always talk to their physician first. Report them to report constipation or development of urinary hesitancy or bladder distension. Teach the patients to change positions slowly to prevent or minimize postural hypotension. Instruct them to avoid caffeine because it can cause them to become more irritable, to avoid alcohol, hazardous activities where the blood levels may become unstable. Instruct them to notify their physician if palpitations, dyspnea, nausea, or vomiting occurs. And like with everything, we want to make sure that we're having that therapeutic response. So are they having less chest pain? Is their blood pressure returning to normal? With it, you want to watch for rebound hypertension or chest pain. And that's what will happen if it's discontinued abruptly. So for example, with atenolol, if the patient decides to stop it abruptly, you can tell them you may not want to do that because you can have rebound hypertension, or you can potentially have chest pain because your body's not used to not having that blocker. You want them to let someone know if they become ill and they're not able to take the medication, and inform patients that they may notice a decrease in tolerance for exercise and have them notify the patient if these problems occur. So this is going back to our heart failure. Inform the patient to report the following to their physician: weight gain of more than 2 pounds in a day or 5 pounds in a week, edema of the feet or in ankles, shortness of breath, excessive fatigue or weakness, and syncopal or dizziness. So whenever you see these, this is all indicating heart failure. And you want to make sure that you're very comfortable with, if my patient says, oh, I've noticed that my feet have swollen, as the nurse, I'm going to instantly think heart failure with it, or I'm going to instantly think, okay, that's a problem. Because as you guys know, patients are very vague when they say things. It's never like, it's never, I felt like a syncopated episode. It's always, I felt a little lightheaded, or I noticed that I gained 2 pounds. And you just want to make sure that you're listening to these so you can kind of be like, oh, that sounds like heart failure. Okay. A patient with type 2 diabetes is taking a beta blocker as part of treatment for hypertension. Which complication is most likely to develop?
See,
Yes, hypoglycemia. All right. And before we go on to our next one, there's a few things I wanted to show you guys. Let me see here. Okay. So the first thing is here, and I've got another one that I will show you, but it's got Adrenergic blockers. This is not the one I wanted. Hold on. Let me find it. It's one she sent me the other day. I had it on here. Where is it? Here we go. That's not it. Okay. So on here, it shows the autonomic nervous system. You've got the sympathetic and the parasympathetic. If it's on, that's your adrenergic agonist. So that's your fight. And if you think about it, that's going to have things like your increased heart rate or your increased blood pressure. So those are all our agonists. And you can write down the medications that you want here. If the adrenergic are antagonist blockers, that's rest. So that's when you're going to have your beta blockers and everything's going to be decreased. For your parasympathetic, for on, you're going to have cholinergic agonist, which is the sludge. So that means everything is kind of increased tears, everything of that nature. Off, you're going to have anticholinergics, so everything is very dry. And that's just one way to kind of help you keep it together. So that way you're thinking of it in that sense. And you can write your medications down under each one so it all kind of stays together. The other thing I wanted to show you is this is just how and you don't have to study it this way if you don't want to. This is just how I personally study it for my beta blockers. So for example, I put on here atenolol. I'll put a little heart next to it and write beta 1 because I know that it's safe for my asthma patients. I write a very brief explanation of what it is. It's to prevent MI, hypertension, chest pain. And then things I'm going to check are things like blood pressure, heart rate, and I do not stop it. With carvedilol, it's a beta 2, so it's lungs. It's used for heart failure, hypertension, and chest pain. And I'm going to check my blood pressure, heart rate, and blood sugar since it's a beta 2. And that way it's just a little bit quicker when you're studying them after you've found out everything that goes on with the drugs, kind of breaking it down that way. Okay. Do we have any questions about those ones before we get on to chapter 20 and 21? Like pull out 20 and 21.
Can you go back to that, what you were just showing on the computer? I can't pronounce it.
On the let me see here.
I guess it's Coreg, Crevidolol.
Oh yeah. Let me share my screen real quick. Okay, so on here with my atenolol, you
Okay.
see it okay?
Yeah, I was looking on the,
It's mostly a way to just study it so it's a little bit easier to keep it all together.
yeah, that looks, that would be helpful.
Yes, because that's just how I found to study it just a little bit quicker. Just so that way I'm getting to the nitty gritty. Because any of your beta blockers, the things you're always going to check for your beta blocker is heart rate. Because heart rate is going to determine whether or not you give that medication and blood pressure. Because if we think about our beta blockers, they're affecting the heart. So it doesn't matter if it's a beta 1 or a beta 2, I'm always checking that heart rate. Now, if I know it's a beta 2, then I know I've got a few things added, such as blood sugar, as well as lungs, so I'm not giving it to an asthma patient.
Okay. Okay, thank you.
You're welcome. Is that just for me? That's just how I keep them, so it's a little bit easier to look at. Okay, let me pull up my other one here. Okay. Okay. Sorry, I gotta pull up something on my phone real quick. Okay, so now we're getting into our cholinergic drugs. So that was the one, let me show you here, with our parasympathetic. So we just finished talking about the sympathetic nervous system. Now we're talking about the parasympathetic, because all of these things are the things that happen just naturally in our body. Okay. Okay, so our cholinergic drugs are drugs that stimulate the parasympathetic nervous system. The parasympathetic nervous system is the opposing system to the sympathetic nervous system. It's also known as cholinergic agonist or parasympathetic mimics. So whenever you see that mimics, it's mimicking the parasympathetic system. So they mimic the effects of the PSNS and cause those the neurotransmitter acetylcholine. Acetylcholine just sends messages along the nerve endings. So with our cholinergic effects, this sled can kind of help you remember these effects. So it's going to cause things like salivation, which is that abnormal, abundant flow of saliva. Our lacrimation, which is the secretion of tears, especially in abnormal abundance. Urination, inability to hold urine in the bladder due to loss of voluntary control of the urinary sphincters, resulting in the involuntary passage of urine. And defecation, abnormal discharging of feces from the body. So these cholinergic drugs basically make everything very wet. So there's two types. You've got your nicotinic receptors and your muscarinic receptors, and they're basically determined by the location and action once stimulated. So the nicotinic receptors are located in the ganglia of both the PNS and SNS. It's named nicotinic because they can stimulate it by the alkaloid nicotine. The muscarinic receptors are located postsynaptically in the effector organs of the PNS, so things like the smooth muscles, cardiac muscles, and glands. And they're named muscarinic because they can stimulate the alkaloid muscarine. So our mechanism of actions, they're going to mimic the effects of acetylcholine. Direct acting cholinergic agonists bind to cholinergic receptors, activating them. Indirect are also known as cholinesterase inhibitors. They inhibit the enzyme acetylcholine esterase, which breaks down acetylcholine, which results in more acetylcholine available at the receptors. So you can either have it directly affecting the receptors or indirectly affecting the receptors. Interacting can be reversible, where they bind to the cholinesterase for a small period of time. Irreversible, they'll bind for a long period of time to form a permanent covalent bond, and the body must make new cholinergic to break these bonds. So the mechanism of action and drug effects. So when we talked about our sympathetic response, that was our fight or flight. Our parasympathetic response is our rest and digest. So when you're also studying these, because they all come from the autonomic nervous system, when you think about the sympathetic ones, those are the ones we just talked about. Those are our adrenergic drugs. I'm thinking of fight or flight. My parasympathetic are all my rest and digest. So if I'm promoting this or stimulating it, then I'm stimulating more rest and digesting. So with this, and this is that picture we were talking about, it can stimulate intestines and bladder. So it causes that increased gastric secretions, increased gastrointestinal motility, which causes increased peristalsis, increased bowel sounds. And peristalsis is just the movement of food through the GI system. Because whenever you're actually listening to bowel sounds, you're actually just listening to, I guess, the food metabolizing through your intestines. And increased urinary frequency. It can can stimulate pupils, so constriction or reduced intraocular pressure, and increased salivation and sweating. So with it, some of the drug effects can cause things like decreased heart rate, vasodilation, because we can all agree that if we're resting, our heart's going to go down, correct?
Yes.
Yes, and it's going to cause bronchoconstriction and narrowed airways. Because think about it, if I'm not going for a huge run, then I don't really need my bronchuses open, right? So that's that bronchoconstriction. So some of our more mechanism of actions and drug effects. At recommended doses, cholinergic primary effect muscle keratin receptors. At high doses, they're going to stimulate those nicotinic receptors. Desired effects are from the muscarinic receptor stimulations, and many undesirable effects are caused by stimulation of the nicotinic receptors. So the higher doses you get is when you get those undesirable effects, when we're hitting those nicotinic receptors. So this is just another one of those kind of nursing memory type things. Our cholinergic crisis signs and symptoms, where we're going to have that sludge, salivation, lacrimation, urination, defecation, gastric upset, and emesis. So our indications, the reason why we would do this, direct acting drugs, they can reduce the intraocular pressure. So it's very useful for glaucoma and intraocular surgery, because an eye with glaucoma, that's why I put this picture on here, is basically going to have a lot of pressure and it's putting damage to that optic nerve. So if I give this and it's going to make it a little bit more wet, then I'm relieving some of the pressure through here. They can be given, usually it's topical application because of that poor oral absorption. So these are some of our other indications. You've got direct acting drug, which is our civilimin. It's used to treat excessive dry mouth or xerostoma. Whenever you see xerostoma, what we're talking about is dry mouth. And that can result from the disorder known as Sjogren's syndrome. And Sjogren's syndrome is basically where they have very dry eyes and dry mouth. So it kind of makes sense why I would give them this medication to cause them to have more saliva, correct? And then
Yes.
yes, the other one is this paralytic that we can also use, and it's used in neuromuscular blocker and general anesthesia. Or anesthesia, sorry. So indirect acting drugs increase acetylcholine concentrations at the receptor sites, which leads to the stimulation of the effector cells. So they can cause things like muscle contractions, can be used for the diagnosis and treatment of myasthenia gravis, which you can see here. This woman has myasthenia gravis because it causes that ptosis, the drooping of the eyelids, and that can either be unilateral or bilateral. They can also be used to reverse neuromuscular blocking drugs and used to reverse anticholinergic poisoning. So if I've got too much anticholinergic, I can give them an antidote of one of these medications. Some of our indications can be used for the treatment of mild to moderate Alzheimer's disease. And then we've got another Alzheimer's disease, which is memantine, which is not a cholinergic drug, but it's also in that kind of realm of Alzheimer's diseases medications. My counterindications would be things like known drug allergies, GI or GU tract obstructions, because think about it, if I've got an obstruction, do I want, I guess, more fluid or more bowel content to be going that way?
I'm sorry, what was the question?
sorry. Sorry, let me say it again. If I have a bowel obstruction, so I've got something blocking my bowel, do I really want more, I guess, defecation to be coming that way?
No.
No. And the reason why is because it's going to cause the obstruction to be worse. No, yes, no, because if you think about it, I'm going to add more to my problem. So that's why if I've got a bowel obstruction or a bladder obstruction, then it's counterindicated for me to give a cholinergic drug. Same thing with my bradycardia. Remember, this is our rest or digest. What's going to happen to my heart rate if I give them this medication?
Get slower.
It's going to get slower. So that's why it'd be counterindicated for somebody who already has a slow heart rate. Same thing with the deficits and defects in my cardiac impulse conduction, hyperthyroidism, epilepsy, hypotension, chronic obstructive pulmonary disease, and Parkinson's disease. So some of my adverse effects, cardiovascular, are things like my bradycardia, my hypotension, my syncope conduction abnormalities, so AV block and cardiac arrest. My central nervous system, things like headaches, dizziness, convulsion, ataxia, gastrointestinal, abdominal cramps, increased secretion, nausea, and vomiting. Because if we kind of look at all of these different effects, if you push it to the extreme, that's when you're going to see things like abdominal cramping, increased secretions, all that. So it can also cause adverse effects such as bronchospasms, because if you remember, if I'm not having to run anywhere, I've got bronchoconstriction, so it's going to have more of those spasms. That increased tears, sweating, salivation. So toxicity and management of overdose of cholinergic crisis. Circulatory collapse, things like hypotension, bloody diarrhea, shock, cardiac arrest, sludge. So all those things, it stands for that salivation, lacrimination, urinary incontinence, diarrhea, GI cramps, emesis. And then your early signs are just kind of things like your abdominal cramping, salivation, flushing of skin, nausea, vomiting. It hasn't gotten to the extreme thing of now I'm seeing shock or cardiac arrest, but I'm noticing some orthostatic hypotension, or I'm noticing that I'm having more flushing. So our cholinergic crisis treatment in the early phase would be things like atropine, and treatment of severe cardiovascular reactions or bronchoconstrictions may result in us needing epinephrine or an adrenal agonist. Yeah.
Okay, I have a random question.
Oh yeah, go for it.
Atropine, that's the eye drops they also give to the dying patients when they have secretions, right?
You can give atropine for more than one reason. So that's what I was talking about. You know how we talked about epinephrine, or we talked about some of those other medications that in different doses or different absorption, it'll have a different effect.
Yeah.
So with atropine, I can give it if my patient has bradycardia to increase that heart rate, but I can also give it in that eye drop form.
Okay.
Can you go back to that, the other page?
This one
Right
here.
there? Yes.
And that's also why when we talk about it, we talk about the importance of knowing your dosage. So that's why it's one of like the rules of medication administration, because dosing can completely change the effect the medication has.
Okay, thank you.
All right, you're welcome. A nurse is assessing a patient who has been taking cholinergic drug for 3 days. The patient has flushed skin and orthostatic blood pressure changes and is complaining of abdominal cramps and nausea. What is the patient's most likely experiencing?
A.
Yes, early cholinergic crisis, because we haven't jumped into that coma or anything just yet. We're still at the early stages. So some of your interactions would be things like anticholinergics, antihistamines, your symptomimics, because they can antagonize cholinergic drugs, resulting in decreased responses, and other cholinergic drugs because they can have that additive effect. So one of the direct acting drugs is our bethical, which increases tone and motility of the bladder and gastrointestinal GI tract. So what this drug basically does is it relaxes sphincters in the bladder and GI tract, which allows them to empty. So it's helpful for post-surgical atony of the bladder and GI tract, because right after surgery, what will happen is because we gave the patient a paralytic or because we gave them a lot of anesthesia, they'll have that lack of muscular tone. So their GI system just basically needs a jump start. So for this one, it'd be kind of like if you had a post-surgical patient and the abdomen felt soft and everything. So you're not noticing anything of that nature, but then you're noticing that there's no bowel sounds, then you would let the provider know and they might prescribe this medication to hopefully jumpstart that bowel again. And how long do we listen to bowel sounds before we say that there's absent bowel sounds? Like how many minutes?
Minutes.
How many?
5 minutes.
5 minutes, exactly. So with this one, you would wait 5 minutes, see if you hear anything. And if you don't, then you would let the provider know. Now, in real world practice, I'd probably get another set of ears before I like jump, because maybe I'm just not, maybe I've got a bunch of cotton in my ears or something. But you would just want to make sure that you waited those 5 minutes, say, okay, I'm not hearing anything, let him know. And then you would anticipate that he's going to order this. But yes, it's used for that treatment of acute postoperative and postpartum non-obstructive urinary retention and for management of urinary retention associated with neurogenic atonia of the bladder. So it can be used for both that as well as abdominal surgery. Counterindications, obviously known drug allergies, hyperthyroidism, peptic ulcers, active bronchial asthma, because it's going to cause that constriction, cardiac disease, coronary artery disease, epilepsy, or Parkinsonism. So Some of your adverse effects might be things like syncopal episodes, hypotension, headache, seizure, GI upset, and asthma attacks. Interactions are your acetyl RC inhibitors or indirect acting cholinergics. Your donzepins are your cholinesterase inhibitors that work centrally in the brain to increase levels of your acetylcholine by inhibiting acetylcholine esterase. It's used in the treatment of mild to moderate Alzheimer's disease. And it's similar to the inhibitors include galtamine and rivastigmine. Some of the counterindications are things like known drug allergies, adverse effects. Once again, we're thinking about if we've got too much of this sludge or cholinergic effects, we're thinking about basically everything being too wet. So that would be things like GI upset. So that increased gastric secretions, drowsiness, dizziness, insomnia, muscle cramps. Some of the more complex ones with the cardiovascular system would be things like bradycardia, syncopal episodes, hypotension, and potentially hypertension. And it can react with your anticholinergics as well as your non-steroid anti-inflammatory drugs. So your pyridostigmine is an indirect acting cholinergic drug that's used to increase acetylcholine by inhibiting acetylcholine isis. Its use is myasthenia gravis. This Tenzolin, or the generic name is that endurofonium, is an indirect acting cholinergic drug that's used to diagnose myasthenia gravis. So what's neat about this Tenzolin test is what happens is they will give the patient a dose of this medication. And if the myasthenia gravis, like this ptosis of the eye, fixes itself, then they can diagnose them with myasthenia gravis. Now, with it, because I've had a lot of people ask me this, well, why can't we just give them that drug and fix myasthenia gravis? The problem is this drug has a very short life, so it doesn't last very long. So it basically just happens long enough for it to be diagnosed, and then they can do the diagnosis and go on from there and give the patient like immunoglobulins or whatever it is that they need for their case of myasthenia gravis. I just always think it's neat because it's like a very quick diagnostic test where they give them the injection and they see that change. So these are some of our reversal effects of our neuromuscular blocking drugs. So we've got our neostigmine that we'll have, and they can be the antidote after toxic exposure to non-drug anticholinergic agents, including those used in chemical warfare. So ginkgo is a herbal product. And the reason I bring up this herbal product is it's another one of these cholinergic agents. It's commonly used for memory loss, vertigo, and tinnitus, so that ringing in the ear. Now, the problem with it is it has a lot of interactions, especially with our anticoagulants. I think I read about it a while back. I think it's the tree it comes from. A lot of the anticoagulants we make also have extracts from this ginkgo tree. So with it, it has that possible interaction, which is going to cause increased bleeding. And if we think about it, a lot of our older adults might be trying to take something for memory. They're also going to be on an anticoagulant. So you want to make sure that you know what their herbal medications are. A 60-year-old woman asks the nurse about taking ginkgo to help her memory. The patient has a history of arthritis, type 2 diabetes, thyroid disease, and hypertension. She is currently taking NSAIDs for arthritis, oral anti-diabetic medications, thyroid replacement hormones, and a beta blocker for blood pressure. What potential adverse effects from the ginkgo would be of most concern for this patient?
C.
C, bleeding.
The
Because we are concerned because that can cause increased bleeding. Any questions about these cholinergic drugs while we're going through these?
I don't have any.
Okay. So continuing on with our nursing implications, you want to note that these drugs stimulate the PNS and mimic the actions of acetylcholine. So that's, once again, remembering that sludge. Assess for allergies and the presence of GI or GU obstructions, asthma, peptic ulcer disease, and coronary artery disease. And like with everything, we want to get that baseline set of vitals and just that system overview. They should be taken as ordered and not stopped abruptly. And they should be spread evenly apart to optimize the effects of the medications. And these medications can be life-threatening, so they should not dose themselves. They shouldn't adjust the dose unless they're directed by the healthcare provider. So for your myasthenia gravis patients, usually what you want them to do is take this medication 30 minutes before they eat to help improve chewing and swallowing. Because myasthenia gravis, a lot of it has to do with that muscle tone. So with it, if they get this medication, it might help them a little so they can actually swallow so their throat's not as dry. When cholinergic drugs are prescribed for Alzheimer's, be honest with caregivers and let them know that this is not a cure. So with it, it just kind of slows the process, but it's not going to cure them of their Alzheimer's. And therapeutic effects of these drugs may not occur for up to 6 weeks. Okay, so a patient with Alzheimer's disease accidentally took 2 weeks worth of cholinergic medication. He is brought to the emergency department and is going into shock and experiencing severe hypotension and vomiting. The nurse will expect which initial treatment?
B.
Yes, it's atropine. Because remember, atropine is basically our antidote for these cholinergic drugs. So with this, if I'm noticing the severe hypotension, I'm going to try atropine first. And if that doesn't work, then I'm probably going to go to that epinephrine. Yes, so nursing, atropine is the antidote for cholinergics. It's written right there. And should be available for patients in the room for immediate use if needed. So that's one of those ones that you do want to know when you go out into practice, that atropine can be used for bradycardia and is the antidote for cholinergics, just because it's something that you want to be readily available to grab. And you want them to notify their physicians if they're experiencing muscle weakness, abdominal cramps, diarrhea, or difficulty breathing. Other nursing implications, monitor for therapeutic effects. So alleviated signs and symptoms of myasthenia gravis in our postoperative patients with decreased GI peristalsis, monitor for increased bowel sounds, passage of flatulence, occurrence of bowel movements. So with this, with our patients, you just want to make sure after they've had that abdominal surgery that they are having those increased bowel sounds if I gave them a cholinergic medication. You want to monitor for with patients with urinary retention or hypotonic bladder. Urination should usually occur within 60 minutes of that bethylcholine administration. In patients with Alzheimer's, improvement in symptoms, improvement in mood, and decrease in confusion. Okay. Any questions about our cholinergic before we jump into our cholinergic blocking drugs?
I don't have any.
Okay. So cholinergic blocking drugs are drugs that block or inhibit the actions of the acetylcholine in the parasympathetic nervous system. They're also known as anticholinergic or parasympathetic and anti-muscarinic drugs. So these drugs are competitive antagonists, which means that they're going to compete with the acetylcholine for binding at the muscarinic receptors. And as a result, acetylcholine is unable to bind to the receptors and cause a cholinergic effect. When they bind to the receptors, they inhibit nerve transmission at these receptors. So basically what happens is they will take the place and they block those cholinergic effects. So for it, and this is where you have to think about our small versus large doses. In the cardiovascular system, small doses of it is going to decrease the heart rate, but large doses are going to increase the heart rate. Because if you think about it, if I'm doing the opposite of rest and digest, what am I doing?
Fight or flight.
Yeah, fight or flight, if we're thinking about it that way. Small doses of the central nervous system decrease muscle rigidity and tremors, and large doses drowsiness, disorientation, hallucinations. So this is more of our cholinergic effects. So with it, our adrenergic is that fight or flight. Adrenergic blockers, feed, breathe, pee, poo. Anticholinergic, can't see, can't pee, can't spit, we'll censor ourselves. And the other thing you can think of is hot as a hair, dry as a bone, red as a beet, mad as a hatter, blind as a bat, because those are the side effects of it. And with your anticholinergic, we do not give them to glaucoma patients, because if I'm drying up the patient with glaucoma, then I'm not relieving that pressure. And our cholinergic are those sludge ones that we just talked about. So in the eye, we're going to have those dilated pupils, decrease a combination caused by paralysis of the ciliary muscles, gastrointestinal, relaxed smooth muscle tone of the GI, decreased intestinal and gastric secretions, decreased motility, and paresthesis. So all of these things are I'm completely dried up. So which finding would the nurse anticipate when assessing a patient with an atropine overdose?
D.
Yes, urinary retention. Because remember, atropine is one of our anticholinergic drugs. So it's going to cause urinary retention because they can't pee. So this is some more of our drug effects, things like increased constriction of the internal sphincter, which results in that urinary retention, decreased bronchial secretions, salivation, sweating, respiratory decreased bronchial secretions, dilated bronchial airways. So for it, some of our indications for our central nervous system would be things like decreasing muscle rigidity and muscle tremors. So things like our Parkinson's disease, our drug-induced extrapyramidal reactions that are usually associated with our antipsychotic drugs, which we'll kind of talk about those more when we get to our psychotic drugs. Cardiovascular affects the heart's conduction system. Low doses going to slow the heart rate. High doses block the vagal effects of the SA and AB node pacemakers, which results in increased heart rate. Atropine is primarily used for cardiovascular disorders. It can be used as a diagnosis of sinus node dysfunction, second degree heart block, and severe sinus bradycardia. So advanced life support. Oops. So by blocking this cholinergic stimulation of the PSNS, it allows unopposed action of the SNS, which once again results in decreased secretion from the nose, mouth, pharynx, and bronchi, relaxed smooth muscles in the bronchi and bronchioles, decreased airway resistance, and bronchodilation, because we're thinking of it kind of like almost like the opposite of our cholinergic agents. So they're usually used to treat things like exercise-induced bronchospasms, chronic bronchitis, asthma, chronic obstructive pulmonary disease. For our gastrointestinals, it controls gastric secretions and smooth muscles that produce gastric motility. So blockade results in decreased secretions, relaxation of the smooth muscles, decreased GI motility, and that paralysis. So they can be used to treat GI disorders such as irritable bowel disease and GI hypersecretory states. For your GU, it can be used for things like incontinence and reflex neurogenic bladder. What you're really thinking about here is all of these kind of disorders that cause somebody to basically, how do I say it? I guess pee a lot. You're going to give them a medication that's going to hopefully stop them from having as much. Our counterindications, glaucoma is a big one for your counterindications. You would not give a patient with glaucoma an anticholinergic drug. And if we think about it, we're thinking about that pressure, because with glaucoma, do we want any more pressure added to that patient?
No.
No, exactly. Things like acute asthma, respiratory distress, known allergies, myasthenia gravis, it kind of makes sense because our cholinergic drugs were all the drugs we use for myasthenia gravis. So if they're doing the opposite, we wouldn't want to give it to them. Acute cardiovascular instability, GI or GU tract obstruction, and we would not give it for benign prostatic hyperplasia. These are some of our adverse effects again. Go through there. Adverse effects, it can cause dilated pupils, causing blurred vision and increased intraocular pressure. So that's why we don't give it to our patients who have any glaucoma problems, is you would not want to give them these anticholinergic drugs, because I don't want any more pressure there. Okay, before administering tolterodine, it is important for the nurse to assess the patient for a history of what condition?
A.
Yes, angle closure glaucoma. Okay. So for our toxicity and overdose, once again, we can do supportive care. So this is if I've given too much of an anticholinergic. You want to have them have continuous electrocardiographic monitoring. They can have activated charcoal treatment of shock. And physostigmine. So if a patient, this is used as the antidote for atropine. So it's important to know if I give too much atropine that I do have something I can give. And the way I always remember physostigmine is it has SOS. And if I'm what's it called? If I give up too much atropine, my heart rate is going to do what? Go up or down?
If you give
It will go
atropine,
up.
it will go up.
Yes. So I'm going to give this in hopes that I'm not raising it too much. So it's SOS because I'm trying to lower it. Because like, you know, like when somebody is stuck on like an island, they're like SOS. So these are some of our interactions. Once again, when given with other cholinergic blocking drugs, it can cause that additive effect, and just being careful with our antidepressants, our digoxin, everything of that nature. So atropine, because I've been talking all about atropine, right? I've just been going around it. Its uses can be things like bradycardia, ventricular asystole, antidote for anticholinergic inhibitor toxicity or poisoning, preoperatively to reduce salivation and GI secretions. Our counterindications are things like our glaucoma, our advanced hepatic and renal dysfunctions, our hiatal hernia associated with reflex esophagitis, intestinal autonomy, obstructive GI or GU conditions, and severe colitis, ulcerative colitis. So with it, atropine is mostly used for patients that have bradycardia. They're suffering from a cholinergic overdose, and if they're about to have surgery. So that's why, who was the one who mentioned the one about the eye drops with atropine?
That was me.
Yes. So we're trying to kind of lower some of those secretions again, because remember, we're trying to dry it up. So that's why you might give it for a patient that's getting ready to pass away, or you could give it to a patient who is getting ready for surgery. So with your surgery, do I really want a bunch of secretions when I'm dealing with a patient who's about to have surgery?
No.
No.
No. So I kind of want them more dry. So I would go ahead and give them atropine in hopes to reduce some of those secretions. And then obviously this is the antidote if I've got too much cholinergic drug on board. So it's used for patients suffering from cholinergic overdose. And then the other one it's used for is bradycardia with a heart rate that's lower than 60. So for example, if I have a heart rate of 34, would this be an appropriate drug to use?
Yes.
Yes. What if I had a heart rate of 160?
No.
You.
No, unless we want to go ahead and get our lovely antidote ready, right? Okay. Our dicyclamine is a synthetic antispasmodic cholinergic blocker. It's a functional disturbances of the GI motility, and it's usually used for things like irritable bowel syndrome. Counterindications, known hypersensitivity to anticholinergic, are angle closure glaucoma, GI tract obstruction, myasthenia gravis, paralytic ileus, GI atony, and toxic megalocolon. So our scopolamine patch, have you guys ever had an end-of-life patient you've had to use a scopolamine patch before?
I've had to put one on
Yes.
before.
There's actually in life care along with oncology.
Oh, are you part of the end-of-life care? So you probably see a lot of
Yeah.
scopolamine patches, correct?
Yeah, and I'm highly allergic to them too.
Really? Oh gosh, wear gloves.
Yeah.
So the thing about it is you can use it for the prevention of motion sickness, but what I have mostly used a scopolamine patch for is my end-of-life patients, because it basically dries everything up. So it's just to help some with these secretions. So that way the patient is a little bit more comfortable, these palliative patients. So they use it for that. So it's completely drying it up. So if I'm thinking about signs and symptoms, something I would think about is if its intended goal is to dry someone up, what do you think is going to happen to their mouth?
It's gonna be dry.
It's going to be dry, exactly. So that's what a lot of these side effects are, is it's just kind of the result of, well, now it's a little too much and we got a little too aggressive with it. So now they're having that dry mouth. So that's why their adverse effects might be things like drowsiness, dry mouth, and blurred vision. So with it though, the scopolamine patch, it can mess with your CNS depressants or alcohol and may increase sedation. So that's the one thing that's a little bit like, you got to be careful with it. So that's why we'd usually use it with post-operative or post-anesthetic or anesthesia, nausea and vomiting, opposed to maybe doing it beforehand, because we don't want it to have that increased sedation. So with it, our nursing implications, you just want to keep in mind that these drugs block the actions of the acetylcholine in the PSNS. Assess for allergies, presence of benign prostate hyperplasia, urinary retention, glaucoma, tachycardia, myocardial infarction, heart failure, hiatal hernia, GI or GU obstruction. And you always want that baseline assessment of vital signs and system overview. They should be taken exactly as prescribed. Overdosing can lead to life-threatening problems, and blurred vision will cause problems with driving or operating machinery. And if your patients experience sensitivity to light, they may wear dark glasses or sunglasses. And then with giving the eye solutions, make sure to apply pressure to the inner canthus to prevent systematic absorption. So it's basically when you pull down the eye, just putting a little bit of pressure there. And with it, remembering what our antidotes are. So remember, our scopolamine patch, which can be used for motion sickness, can cause dry mouth. So you might be handled by things like chewing gum or frequent mouth care. They should check with their patients or their physicians before they use any over-the-counter medications. And our atropine overdose antidote is what?
That PH word, I can't say it.
Yeah, our bisotigmine. So our anticholinergics taken by older adult patients may lead to higher risk for heat strokes. Teach them to limit physical exertion by avoiding high temperatures and strenuous exercise, and that they're taking enough fluid intake and salt intake. Because remember, this is drying them up, so we want to counteract that. So with it, you want them to report the following symptoms to their physician: urinary hesitancy, retention, constipation, tachycardia, palpitations, tremors, decreased sweating, hallucinations, anything of that nature that can't see, can't pee, can't spit, can't, you know. You want to always monitor for your therapeutic effects. So making sure that for your patient who has Parkinson's disease, that they're having fewer tremors, decreased salivation and drooling. And then for patients with your urinary problems, that they're having better urinary patterns, increased time between voiding. So it's not like that as soon as I stand up, I have to go use the bathroom, anything of that nature. Okay. So do you guys have any questions or anything like that right now?
I don't right now, but 10 minutes in the future, that might be a different story.
It's all about the trying to get it in. Like I said, what I would say is just try to see what the receptors do and what these things do naturally, and then try to put the drugs in afterwards. Because if you can see what the receptors do, it kind of helps you when you're going through it.
Okay.
And just like remembering, no questions, thank you. And just remembering things like, for example, if I've got a cholinergic blocking eye drop, then I know that's going to cause dilation of the pupils. So making sure that you know, are my pupils getting constricted or they're dilating with these different medications? And that might help you kind of keep things together too. All right, well, if that is everything, I will see you guys next week. Enjoy the rest of your fall break, and I will put up this recording so that way you guys can look at it a different date as well, okay?
Thank you.
You're welcome. Bye, guys.
Bye.